Now we're going to transition to some conversation regarding our infectious etiology, starting with hepatitis and comparing the viral types. So we have Hep A through E. Now it's important to note that these are not all the same viruses. Hepatitis A, C, D, and E are all RNA-based viruses, but even they are not in the same cat family. You have a hepavirus, a delta virus, a flavivirus, and epicornavirus. Hep B is the cheese that stands alone. It is a DNA-based virus. So that is an important one to note to just keep in mind. You do need to know DNA versus RNA, double versus single-stranded, all of those pieces for Mplex 1. Now, transmission, you have two types that are fecal oral, Hep A and E, and then you have Hep B, C, and D that are typically blood, sexual, or mucosal transmission. Of note, Hep D does require a co-infection with Hep B to actually cause a superinfection or a co-infection. Incubation periods, less important to know for this exam, but important to know clinically. Chronicity, it's important to know that Hep B and C are going to be chronic, versus A and E are going to be acute and self-resolving, typically over time. Hep D is going to increase the severity of hepatitis B. Fulminant liver failure, you can see that some in hepatitis B, rare in Hep C, and yes, when you have a co-infection with hepatitis D. And then of note, in pregnancy, if you got hepatitis E, 30% of patients who get hepatitis E in pregnancy could see liver failure. Vaccination based, again, not important for NPLEX 1, but important clinically. And then risk of hepatocellular carcinoma, really your chronic. So Hep B, Hep C, and co-infection with hepatitis D. So again, the one kind of rare, strange, and peculiar is hepatitis E in pregnancy. 30% of maternal mortality occurs due to fulminant hepatic or liver failure. And this happens typically more in developing countries where there's flooding with contaminated water. Not typically routinely tested in the United States, but this is a high yield board fact because it's rare, strange, and peculiar. Um, Serology interpretation, definitely high yield for NPLEX 2, not so high yield for NPLEX 1. So really not an important thing to try to memorize. I wouldn't actually spend a lot of time on this component on this factor. Um, Thinking then about what could happen to our liver, how could things progress into cirrhosis? And cirrhosis is an end-stage chronic liver disease. It's from diffuse fibrosis and regeneration of nodules within the liver that then leads to hepatocellular or hepatocyte failure, and then portal hypertension, increased pressure within the portal system. Causes are your A, B, C, D, and E's. So alcohol is the most common in the United States. And alcoholic steatohepatitis can lead to cirrhosis. Biliary causes, lots of different options, but biliary causes can also back up and lead to cirrhosis. A cryptogenic NAFLD or NASH, this is the fastest growing kind of cause globally. Different drugs, and then exogenous viruses, typically Hep B and C, or hereditary with Wilson's disease, hemochromatosis, alpha A1 antitrypsin deficiencies, etc. What else? You not need to know these other two factors clinically for boards one. Complications of cirrhosis would be ascites. Ascites, we see portal hypertension leading to increased hydrostatic pressure as well as decreased albumin because the liver's failing, which leads to decreased oncotic pressure in addition to sodium and water retention due to the activation of the ROS system. So it's just the perfect storm. We'll see then that our serum albumin you can kind of calculate that via the ascites albumin. But ultimately, you're essentially just pushing fluid out of your portal system due to that high hydrostatic pressure, low oncotic pressure, and you also have more fluid in the system because you're pulling in sodium and water from the kidneys, and that sets you up perfectly for a perfect storm to have ascites. So this would be your high yield point here. You can see potentially a spontaneous bacterial peritonitis from this as a complication. This is a bacterial infection of ascites fluids. Typically, it's a gram-negative enteric bacteria like an E. coli or a Klebsiella pneumoniae that's already kind of in that system. And this would be obviously a big bad infection that patients would need treatment quickly. Other cirrhosis complications, hepatic encephalopathy. When the liver is failing, you'll see an increase in ammonia from gut bacteria and from our portosystemic shunting that bypasses the liver and that leads to neurotoxicity. Essentially, we can't deal with our nitrogenous wastes. A classic sign is asterixis, which is a flapping tremor. You also can see in uremia or hypercapnia. Um, some kind of other kind of concomitant symptoms that could occur would be a GI bleed, infection, constipation, hypokalemia, and obviously you're having changes in mentation. Esophageal or gastric varices on your rubric as well, or your blueprint as well. Portal hypertension leads to collateral circulation, kind of trying to go around the liver portal system to the systemic circulation. And these lead to varices and this kind of appearance that we call caput medusae and hemorrhoids. If these rupture, that can lead to a massive upper GI bleed, and the mortality is pretty high for these scenarios. Hepatorenal syndrome, this is a functional renal failure. There's no intrinsic renal or kidney disease. It's only occurring due to the advanced cirrhosis. You'll have splanchnic vasodilation, which leads to a decrease in effective arterial blood volume, which will lead to constriction of our renal kind of arterial, so renal vasoconstriction, which decreases GFR. So that kind of leads to this like renal failure that has no issues with the kidneys. Um, and then last but not least, hepatocellular carcinoma. This is the most common primary liver cancer and it arises in a cirrhotic liver. Risks hepatitis B and C, alcohol, NASH, hemochromatosis. Um, obviously, the key kind of component here would be knowing that this is the most common primary liver cancer. Cirrhosis would be what precedes it, and these would be your risk factors. Some other metabolic liver diseases that are kind of high yield board favorites can be obviously hemochromatosis. This is where you have a defect in the HFE gene, which is also labeled C2H2Y, which leads to increased iron absorption in the gut. Some classic features are going to include bronze diabetes, restrictive cardiomyopathy, where the heart's not really moving well, hypogonadism and arthritis, specifically in the second and third metacarpals, cirrhosis as well. Some key labs, again, you're looking for your iron components and treatment we're not going to worry about for now. Wilson's disease, this is due to a ATP7B mutation, which leads to a decrease in copper excretion in the bile. So you have a copper accumulation. So hemochromatosis, iron, Wilson's, copper. So you'll see in the cornea Kaiser-Fleischer rings, these like brown rings in the cornea, liver disease, neuropsychiatric behavior, tremors, and then alpha-1 antitrypsin deficiency. This is where you have a misfolded alpha-1 antitrypsin protein that accumulates in your hepatocytes in the endoplasmic reticulum. So a misfolding. This often gets tagged with ubiquitin for destruction. This can lead to a kind of a picture of like an emphysema that's more like lower lobe plus liver disease with cirrhosis. Um, and then last but not least, you have primary biliary cholangitis, which is autoimmune disease where the immune system attacks and destroys the small bile ducts in the liver, which leads to inflammation and scarring, fibrosis, and potential cirrhosis. Oftentimes, this is seen in more middle-aged AFAB individuals, pruritus, fatigue, xanthomas, increased alkaline phosphatase is greater than transaminases. Moving into, well, actually, we'll pause and then we'll move into the pancreas.